Bismillahirrahmanirrahim. In this lecture, we will mainly focus upon the topic of thyroiditis. Now, what is thyroiditis? It is basically the inflammation of thyroid gland. Inflammation of thyroid gland. Now, there are three main types of thyroiditis. The one is Hashimoto thyroiditis. The second is subacute lymphocytic thyroiditis, and the third is granulomatous thyroiditis. Now we mainly focus upon the Hashimoto thyroiditis. Hashimoto thyroiditis. Hashimoto thyroiditis, it is basically an autoimmune disease. It is an autoimmune disease that results in the destruction of thyroid gland. So there would be progressive thyroid failure. Progressive thyroid failure. Now we mainly focus upon the pathogenesis of Hashimoto thyroiditis, that what is the cause of this autoimmune disorder. Pathogenesis is that there is the breakdown in the self-tolerance. Okay, breakdown in self-tolerance to thyroid autoantigens. That normally the antibodies are not formed against the antigens of our own body. For example, the thyroid autoantigens, due to any cause, the antibodies began to form against these thyroid autoantigen, and then consequently there would be the destruction of thyroid gland and there would be the thyroid failure. Now we discuss about it. What are the triggering agent? What is the initiating agent due to which there is the breakdown in the self-tolerance into the thyroid autoantigen, that the antibodies begin to form against that thyroid autoantigen. Now the first is the abnormality of the regulatory T cells. Whatever the cause, these regulatory T cells, they cannot function properly, and they order the other autoimmune cells to form the B cells and plasma cells to form the antibodies against the thyroid antigen. The second cause could be the exposure of normally sequestered thyroid antigen. Exposure of sequestered thyroid antigen, that normally the thyroid antigens, they are not present in the blood and they are not exposed to the immune cell due to an unknown mechanism. Due to any cause, these sequestered thyroid antigens, they are exposed and the antibodies begin to form against them. The third cause could be any genetic abnormality. For example, there is the polymorphism of the immune regulation associated genes, and such patients are more susceptible to develop the Hashimoto thyroiditis, an autoimmune disorder. So these three were the triggering agents. Now if the antibodies are formed against these antigens, then there would be the apoptosis of thyroid epithelial cells, that the follicular epithelial cells or thyroid epithelial cells, their apoptosis would start, and there would be the depletion of these thyroid epithelial cells, and the thyroid parenchyma, it would be replaced by mononuclear cell infiltrate, that plasma cells, T lymphocytes, B cells, monocytes, they would all replace the thyroid parenchyma. So there would be the replacement of thyroid parenchyma by mononuclear cell infiltration and by fibrosis. Fibrosis would also occur. So, what would occur in pathogenesis? We discussed that there would be mainly in the breakdown in self-tolerance to thyroid autoantigen, and the triggering agent was there was be the abnormality in regulatory T cells, or there was the exposure of the sequestered thyroid antigen to the immune cells, or there could be the genetic cause, any genetic mutation, and as a result there would be the apoptosis of the thyroid epithelial cells, there would be the depletion of thyroid epithelial cells, and the whole thyroid parenchyma, it would be replaced by the mononuclear cell infiltrates, that is lymphocytes, plasma cell T lymphocytes, and the widespread fibrosis would occur. Now we discuss the immunologic mechanism of thyroid cell death. It comes under the pathogenesis, that what immunologic mechanism occur. Then these the thyroid follicular epithelial cells, their death could be occur either due to CD8 positive cytotoxic T cells or CD4 positive helper T cells, which produce the inflammatory cytokines like interferon gamma. This interferon gamma, it activates the macrophages, and so there would be damage to the follicular epithelial cells. And third is the antibody dependent cell mediated toxicity. Antibody dependent, that the antibodies, they attach to the follicular epithelial cells, and then the T cells in the macrophages, they engulf those cells. So immunologic mechanism of the thyroid epithelial cell death is CD8 positive cytotoxic T cell mediated death of the follicular cells, or there would be CD4 helper T cells, that is cytokine mediated follicular cell death, and the third is the antibody dependent cell mediated death. Now we discuss about the morphology of the thyroid gland in the Hashimoto thyroiditis. Morphology. Grossly, the thyroid gland would be diffusely enlarged. Thyroid gland diffusely enlarged, and the capsule would be intact. Capsule would not be damaged, it would be intact and well demarcated from surrounding structures. And if you cut the thyroid gland, it would be pale looking and somewhat nodular. On microscopy, what you will find that there would be the extensive infiltration of parenchyma by mononuclear inflammatory infiltrates. That is, if there is a, for example, if there is a cut section of the thyroid gland and we observe it under microscope, you will see that in the widespread area, the most of the thyroid parenchyma, it is replaced by mononuclear lymphoid inflammatory infiltrate. Okay, these are the plasma cells, these are the lymphocytes, and the macrophages, they would be present as well, and just some germinal centers would also be present. And the thyroid follicles, they would become atrophic. Most of the thyroid follicles, they would become atrophic, and the lining of the follicular cells, they would be the metaplasia. Normally the thyroid follicle cells, they are lined by the locuboidal epithelium. In this thyroid in Hashimoto thyroiditis, these low cuboidal epithelial cells, they would be replaced by the cells which are known as Hurtle cells. Hurth, Hurtle cells. The Hurtle cells, the cytoplasm of the Hurtle cells, it is eosinophilic and finally granular. Okay, so the follicular cells, they would be lined by the epithelial cells which are called Hurtle cells. And the third is that interstitial connective tissue, it would be increased. There would be abundant interstitial connective tissue and marked and widespread fibrosis, but it would be confined within the capsule. So I am repeating the morphology of the Hashimoto thyroiditis, that on grossly the thyroid would be diffusely enlarged and its capsule would be intact and well demarcated from the surrounding structures. While on microscopy, there would be the extensive infiltration of parenchyma by mononuclear inflammatory infiltrates like small lymphocytes, like plasma cells, and well developed germinal centers would be present. Whereas thyroid follicles, they would become atrophic and they would be lined by epithelial cells which are known as Hurtle cells. It is basically a metaplastic response to the of normal low cuboidal follicular cells, that the low cuboidal follicular cells, they are replaced by this kind of cells known as Hurtle cells. And the third is that there is a widespread and extensive fibrosis, but this fibrosis would be confined to the capsule and not extend beyond the capsule. These such patients, they are also at risk of developing the other autoimmune disorders like type 1 diabetes, mellitus, like SLE, like myasthenia gravis. Now this was all about the thyroiditis and Hashimoto thyroiditis. Thanks for joining.